spending a lot of time together talking about
Yeah.
cancer in Iowa, and that's going to be our topic. But before we talk about cancer in Iowa, Sarah, let's get to know you a little bit. So once you say a few words, people will know you're not from South Dakota or Minnesota or even Iowa.
I am not. I grew up in England and I have spent most of my adult life in Alaska. So I moved from Alaska to Iowa. And so I have this kind of hybrid English American accent.
Yes. So you grew up in England. And what part of England?
About an hour west of London in a little town that no one has ever heard of.
Okay. So like when did you go to high school in England?
I actually went to boarding school, and I went to
Boarding
boarding
school.
school about an hour south of London. I loved to learn when I was a kid, and I was completely unmanageable because this was in the days before Google. And so my one of my teachers said to my mom, "I think Sarah needs to go to somewhere that will keep her busy intellectually." So
So they just send you away and
I
lock
wanted
you
to
up.
go. To be clear,
Okay.
this was not my
Okay.
mom. My mother packed me away. I
Okay.
really wanted to go.
And so how many like kids in your class at the boarding school?
There were 850 pupils total for all 7 years. There's about 100 per year. This was in
Oh,
England, high school is done from 11 to 18.
okay.
A little bit
And,
different.
and what was your claim to fame in high school years?
In high school, I was the youngest ever member of the first hockey squad, which is the best hockey squad. And I can't really claim to fame. The only reason that happened is because they really needed goalkeepers.
Okay.
And I was the only one who stepped up, and I turned out to be pretty good. So
Gotcha. And this is field hockey or ice hockey?
field hockey.
Field
I
hockey.
always I always forget that you guys call it field hockey.
So field hockey. And then how did you happen to go from England to Alaska?
That
Or
is a really good
or,
question.
or did you continue your college or university education in England?
Yes, so I did my undergrad actually in archaeology and anthropology at the University of Cambridge, and I studied paleo diet. So that is the diet of people who lived thousands of years ago, and we would take bone samples and we would use these particular biomarkers and try and use these biomarkers to indicate what people were eating. And when I graduated with my undergrad degree, I loved my honors thesis. I really enjoyed it. But I thought to myself, I kind of really want to work with people who are alive right now, to put it bluntly.
Oh,
And I thought this will be so much easier. We can just ask them what they eat, which is um, very naive. And I had no idea at the time kind of what I was getting in for.
so
And
okay,
I was
go
going to
ahead.
say, sorry, about 6 months after I left, I had an email from my former um, thesis advisor, and she said, "I just saw an advertisement for a position in Alaska. Are you interested in moving to Alaska? You'd be great for this." So that's how that happened. I moved to Alaska in the middle of winter.
What was the position?
It was a PhD position to develop the same biomarkers of diet that I was using in my undergrad, to develop them in for use with an Alaska Native population to understand the relationship between diet and chronic disease risk. So I already had experience with the biomarker, and it was just a case of learning all the epidemiology from there.
And so then you were in Anchorage or
So I was in Fairbanks for my graduate degree. I have lived in Anchorage. I've lived in both Fairbanks and Anchorage. And I moved to Fairbanks in the middle of winter.
oh my
I had
gosh.
this like little European ski jacket that I had bought at TK Maxx. And I felt so prepared and proud of myself. And I had no idea how underprepared I was. Probably like you going to Patagonia in your jeans and t-shirts.
Wow. So you got your PhD in
Mhm.
Alaska.
Yep.
And what was your thesis?
It was looking at these biomarkers of diet, and I was really interested in traditional and non-traditional food use among this Alaska Native population that we were working with, and then looking at how traditional and non-traditional food use was associated with biomarkers of cardiometabolic risk, so blood pressure, HbA, blood glucose, blood lipids, those kinds of things.
So we're going to be talking about cancer. So
Yep.
at some point you transitioned
I did.
from the diets of indigenous Alaskans to cancer. How did that transition happen?
So for my postdoc, I went and trained with the National Cancer Institute because I decided I wanted to learn more about cancer, and I still did diet and cancer. And then after my postdoc, I had an opportunity. It was just personally, my husband and I decided that Alaska would be good to return to. And I had an opportunity, and I had always really valued the Alaska Native Tribal Health Consortium. I thought the work that they did was really community engaged, and I could really, I loved working at the National Cancer Institute, but one of the things that I really missed was the ability to like shake the hands and see the faces of the people whose work I was, whose lives I was impacting with my work. And I thought that that was the kind of work that the Alaska Native Tribal Health Consortium did and still does do. And so they had this job opening to be their cancer surveillance director. And I had no idea what that meant. I didn't know what a cancer registry was, but I thought, heck, why not? I'll apply. And I applied and I got the job, and I've been in cancer registries ever since. I love it.
And so you were in the cancer surveillance work in Alaska for how many years before you came to Iowa?
About 6.
Okay.
And then I moved to Iowa about 4 years ago.
Okay. What's the biggest difference between living in Alaska and living in Iowa?
There's no mountains in Iowa that I found. That's a
Uh-huh.
big difference. And if you know anywhere that has
The
mountains,
highest point in Iowa is on a pig farm in northwest Iowa.
okay, good to know.
Yeah.
What else is different?
How about the universities?
The universities are very different.
Okay. Because your position is with the cancer registry, but are you also like an associate affiliate or associate professor in
Yeah,
epidemiology? And do you teach undergrad or
I
graduate?
do. And you gave me a promotion, so thank you. I'm actually an assistant professor of epidemiology at the University of Iowa. And I love it. I teach mostly masters in public health students. I teach the Epi 101 course, the Intro to Epidemiology, and I love that. I will say, though, that thinking about how different the University of Alaska and the University of Iowa is, the University of Iowa has a lot of resources that the universities in Alaska maybe don't. But it feels really small here at the University of Iowa because everybody is so friendly and so collaborative. And I think that that is a strength that Iowans have generally. That's one of the things I've noticed about being in Iowa, is that even though there's more people here in Iowa, it feels like there is community, and the people are just so welcoming and so lovely, and so willing to talk and collaborate and listen and learn. And
Yeah, I do think that that is a strength of the upper Midwest. I grew up in South Dakota, and I think part of it is in South Dakota. I think we feel like if you're from somewhere else, you've got to be better than we are. So we were welcoming to anyone.
I'm
We
not
think we
sure that's
maybe are
true,
equal
but
to North Dakotans. We probably don't think that North Dakotans are better than us, but definitely Iowans, Nebraskans, anywhere else you're better. Before we talk about cancer in Iowa, could you tell our audience a little bit what is epidemiology and what is a cancer registry?
Absolutely. So epidemiology is the study. I'm trying to remember my definition that I teach our Epi 101 folks. The epidemiology is the study of the distribution of disease and the determinants of distribution of disease. So basically, to break that down, it's who is getting different types of diseases and why are they getting those different types of diseases. So we're really interested in cancer. So we might ask the question, who is getting cancer? What types of cancer are they getting? And why are they getting those cancers? And that's one of the things that the cancer registry can tell us, or at least the first 2 questions are questions that the Iowa Cancer Registry can help us with.
Right. And so we have an Iowa Cancer Registry.
Yep.
I assume we don't have an Iowa Pneumonia Registry, an Iowa Heart Disease Registry. Why do we have an Iowa Cancer Registry?
Yes, so that's a great question, and I don't actually know about the pneumonia and heart disease registry, but what I can tell you, because there is a list on the CDC website, I hope it's still there, that covers all of the notifiable diseases in the country. And there are many notifiable diseases. So there are actually diseases other than cancer for which facilities are legally obliged to report. that cancer is one of the ones for which I would say we have the most robust system in place. And so since 1982 in the state of Iowa, the cancer has also been a reportable disease in the state. So it's reportable at both the federal and the state level. And the Iowa Cancer Registry is the designated agent for collecting the cancer information. So what that means is that we work with facilities, most often that's hospitals, but it could be pathology labs, pharmacies, places, dermatology clinics, urology clinics, to really get information on the cancers that are being diagnosed in Iowa. And this enables us to tell Iowans statistics like we have the second highest rates in the nation for cancer, and that our most common cancers are breast, lung, colorectal, prostate, and melanoma. It's the work that we do at the registry that's, I think of the registry as maybe the foundation of everything that we do in cancer prevention, cancer treatment, and cancer control. Because in order to be able to prevent cancer, in order for you to be able to treat cancer, in order for us to know how many doctors we need to treat however many cases of cancer that we have, we need to know how many cases of cancer and what types of cancer we have.
Right.
And that's what the Iowa Cancer Registry does. Is it gives
And
us
so,
that.
as you said, it's a reportable disease, so we're legally obligated to keep track of it.
Yep.
And obviously, it doesn't make sense to just put it all in a database and just let it sit there. That we have people like you that are director of research to actually not just collect the data and put it out in a manual, but then to actually conduct research related to epidemiology and help to determine associations and hopefully causes, effects, and other interesting things. What before we get into the data 2025, how do you, as a director of research at the Iowa Cancer Registry, what do you think about when you think about a research project that you're going to do through the data that you collect at the Iowa Cancer Registry?
So I think one of the first things that I would like to say is that we consider ourselves kind of stewards of the data. And I really like to think of the registry as a collection of stories. And because every number in our registry is a story, right? It's a person who has had a diagnosis of cancer, and we are collecting the story of their cancer journey. And so for that reason, we have very, very strict protocols in place about how we store the data, about who's allowed to see the data, and about who we share the data with and how. So that's really the principle that underlies the work that we do. And then when we're thinking about what kinds of research and what kinds of data we can do, I think really the sky's the limit, or at least the data's the limit. So one of the things, I do a lot of work in what's called health services research. So this is really trying to understand what treatments people are getting, and specifically who's not getting the right treatment, and try and figure out why. So I look at, you know probably better than I do that there are guidelines that say which treatments that patients should get. Mm-hmm. And so we can use the registry data to look at whether folks are getting guideline concordant treatment and see if they're getting timely care, and try and figure out, for example, I know Mary Charlton very well. A lot of her work, she's the director of the Iowa Cancer Registry, has been looking at how do we get rural Iowans high quality cancer care? And how do we make sure that we are leveraging the data that we have at the Cancer Registry to help folks in rural Iowa get high quality cancer care? So really the data's the limit in terms of what we can do in research. We just have to make sure that we're doing it really responsibly and really respecting and protecting the stories of those who are in the registry.
Okay. Well, let's turn to the Cancer in Iowa 2025. So together, you and I and several others participated in a news conference about 6 weeks ago, where
only 6 weeks ago.
Was it that long
feels like
ago?
a lifetime ago.
Where the data was released, and obviously you don't give every little piece of data, but there's a beautiful report that you have right there that highlights what's going on in Iowa in 2025. So why don't you share with us some of the highlights of Cancer in Iowa 2025?
Yeah, absolutely. So I'm sure that most people in your audience will have heard that we have the second highest rate of new cancers in Iowa compared to all the other states in the nation. We are second behind only Kentucky. And that continued in the 2025 report. We estimated about 21,200 new cases of cancer will be diagnosed in Iowa in 2025, and about 6,300 people will die from cancer in Iowa in 2025. One of the reasons that we wanted you to be a part of this report is because every year we focus on a different topic. And this year we decided to focus on survivorship. And obviously, I think folks in the room know that you are one of the key thought leaders in this space in the state. And so as our incidence rate is climbing, we're one of only two states in the nation that has a climbing rate of new cancers. And fortunately, our mortality rate is declining, it's going down. And what that means is we have an ever increasing number of people who have had a diagnosis of cancer at some point in their life. So we estimate that currently approaching 172,000 Iowans, that's about 1 in 20 or 5% of Iowans have had a diagnosis of cancer at some point in their life. And so that's really where we wanted to focus this year's report. So we have each year, like I said, we have a special section. This year, we really focused our special section on cancer survivorship. So we have pages on kind of sharing the statistics about cancer survivorship. We have pages on cancer survivor needs, and then just different resources that folks with survivorship concerns who are interested in survivorship, who have had a cancer diagnosis, might be interested in. And then we featured, this is a new thing this year, which I really loved, we featured some survivor stories as well as, and you might recognize this delightful picture, this is folks who are engaging in survivorship care and research in Iowa, and your pretty face is right there at the top.
Well, thank you. It was great to be part of that special section on survivorship. Back to kind of the statistics, and you mentioned that Iowa, number 2, but that we're one of 2 states whose incidence is going up, and the other 48 states, their incidence of cancer is actually going down. What is the other state that has an increasing incidence of cancer?
It's Utah, and you might be able to imagine that their rate is substantially lower than ours to begin with. So I can't remember where they are in terms of the ranking, but it's close to the bottom.
Mm-hmm. But just statistically, theirs is going up, and
theirs is also going up.
I know that you don't like to speculate. If I were to speculate, I would say, well, maybe their population is becoming less homogenous, and that we might. I'm probably incorrect about this, but you might think of Utah as a lot of Mormons that have fewer modifiable risk factors that some of the other states do. But as Salt Lake City becomes more of an international city, and you get people coming in who might have more of the bad habits that some of us in other states have, that maybe that's causing their incidence to go up.
Yeah, population changes can definitely contribute. A couple of things. First of all, cancer is really complicated. So, I think you were implying there, is that there are a lot of different what we call risk factors for cancer. We like to think about cancer as like a pie, right? I don't know if anybody's old enough to remember my favorite board game, Trivial Pursuit, but we like to think of cancer as like a pie, and risk factors are the things that fill up our slices of the pie. And when you filled up all your slices of the pie, unfortunately, in this case, you don't get to win the game. You get a diagnosis of cancer. And so each person, each population might have more slices in their pie. They might have different contributors. And so it's just really complicated to figure out what causes cancer, both at an individual and a population level. And so that's why we talk about things like risk factors and things that can increase or decrease our risk of cancer. The other thing to think about, and this I think is probably relevant for both Iowa and Utah, is that the things that are, quote, caused the cancers that we are seeing now happened 5, 10, 15 years ago. So there's this what we call latency period, this lag time between the things that are causing the cancer and the actual diagnosis of cancer itself. So, for example, we can think of a risk factor that is very strong for many cancers is smoking. And you can think about somebody, who might start smoking, and then it might not be till 10, 20, 30 years later that they receive a diagnosis of cancer, excuse me. And so it's kind of, that makes it even more difficult to untangle, right? It's not just, how is Utah changing? How is Iowa changing? It's how did these places change? What were we doing 10, 15, 20 years ago that may cause the rates that we're seeing today?
When you look at the types of cancers, and you mentioned the most prominent cancers in Iowa, it seems to me that when you look across the entire country, the ones that are most prevalent are pretty much the same around the country. Breast cancer, prostate cancer, lung cancer, colorectal cancer. In terms of incidence, those tend to be the big four in all of the states.
Yeah.
Is that correct?
As you rightly say, we call them the big four because they usually are the top four. There are some places and in some populations where that may be different, but often those four are the leading cancers.
Mm-hmm. And then to make a point that's obvious to you and I, but maybe not to everybody in the population, that the breast cancer and prostate cancer are really high in terms of incidence, but most breast cancers and most prostate cancers are not deadly, and so they're not the top two in terms of death, and that lung cancer is the number one cause of cancer death in Iowa and probably every state in the union.
I don't know whether it's every state, but if it's not, it's close to every state.
Mm-hmm.
But I think it probably is every state. I'd have to check that. Let me get back to that.
Okay.
But you're absolutely right, and that's one of the things we actually talked about in this year's report is that the number of survivors that we have that a state has is going to be represented more heavily by those cancers that have high incidence and low mortality. So we have a larger proportion of our survivors are breast and prostate cancer survivors compared to, for example, lung cancer, which, like you say, can be very deadly. And so a smaller proportion of Iowa's survivors has been diagnosed with a lung cancer.
Another cancer that's, I think, fascinating to look at is the kind of the inverse of prostate cancer, and that's pancreas cancer, where the incidence in terms of the number of people diagnosed with pancreas cancer is fairly low. Like, I don't know, it's 10th or 8th or something, but in terms of the number of deaths.
8. I got this page 2.
Yes, and by the way, we will put in a link so that everybody can go and copy this report. So it's 8th cancer in terms of incidence, but it's like number 4 in terms of death, I think.
Yes, you are correct. Nope, 3rd. Sorry, I'm just, there's so many numbers. Sometimes I get them muddled up in my head, and I made sure I checked so that I can make sure I'm giving you the right information. So you're right. You're absolutely right. So pancreatic cancer is our 8th most common cancer, but it is our 3rd most deadly cancer.
Behind lung
and colorectal.
Right. And so those, what as a researcher, how would you, like, if you were going to do research on, let's say, prostate cancer where there's high incidence but a low death rate versus pancreas cancer with a low incidence but a high death rate, how does your researcher brain say that we could mine the data or look at the data in a way that might inform us of something that could be useful?
Oh, I think it really depends on the question you're asking. And there are so many different questions that you could ask. I think one of the things that stands out to me as a registry person is that some of the biggest differences between, for example, breast and prostate cancer compared to lung and pancreatic cancer is that, as I'm sure you know, Dick, breast and prostate cancers many of them tend to be diagnosed early. We have screening tests, particularly for breast cancer, that are very efficacious and very effective, whereas we don't necessarily have that for pancreatic cancer. Lung cancer, we do have screening available, but it's not widely uptaken.
Mm-hmm.
Uptaken
utilized. Yes.
Thank you. Utilized. It's not widely utilized. We actually have really high prevalence of lung cancer screening in Iowa. I saw some figures that were about 11%, but I think it could be somewhere between 11 and 15%, and that's high compared to many other states. And so you can
But
see we have a lot of room for
But
growth.
compared to mammography, just
Yes,
it makes your point, like mammography is like
about 80%.
80%. So
Yeah.
80% of eligible patients, women,
Yep.
are getting their mammograms, but only about 16% of eligible individuals. And for mammography, it's all women. For
Between
lung
the ages
cancer,
of 40 and 75, I believe.
correct. But for lung cancer, it's just for individuals who have a smoking history.
Mm-hmm.
So a 20-pack year smoking. So not as many, but it's just not become as not as many people know that there is a
Yep.
valid screening test for lung cancer for those individuals who are at higher risk, and the risk is defined by cigarette smoking.
Yeah,
Yeah.
absolutely. And one of the things that we like to see in our cancer data is that as we put in a screening program, we like to see that the stage that we're detecting these cancers will become earlier and earlier, because as I'm sure that you live with every day as an oncologist, um, the cancers that are diagnosed earlier are the ones that are easier to treat, with lower impact on quality of life for the patient, and are more likely to be curative. So those cancers like lung and pancreatic cancer, where we're diagnosing them later, that's one of the reasons that they have a high mortality, is because we're catching them late when treatments are less likely to be curative.
Mm-hmm. Another factor, and we talk about modifiable risk factors, but one risk factor that's not modifiable, but is probably the one of the strongest associations, is age. The
Mm-hmm.
older we get, the
Yep,
more likely we are to develop cancer.
absolutely.
And but right now we don't consider that a modifiable
If
risk
anybody
factor.
knows a way, let me know. I'd love.
Yeah, the planet is doomed if it becomes a modifiable risk factor. But the
Yeah,
other risk factors also factor in, and we think of them. And you make a point in the Cancer in Iowa of going through where Iowa stands in terms of the rest of the country on some of those modifiable risk factors, and maybe remind our audience what are those risk factors that we consider modifiable risk factors that we have some control over.
absolutely. Do you mind if before I do that, I pick up one of your other points about age, just real quick?
You're the star of this program. You're the boss. I just
I don't think I'm the boss, but thank you. So one of the questions we get at the registry, I would say a reasonable amount, is do we have the number 2 rates because we have an older population in Iowa? And the answer to that is no. The rates that we are putting out and the rates that we are comparing ourselves to nationally are all what we call age adjusted. And this means that we have done some statistical finagling. I think that's the technical term, to ensure that age is not impacting the rates, and that the rates are comparable, and that the age, what we call the age structure of the population, that effectively means how old your population is not impacting the rates. So I just wanted to put that out there to say that we don't have the number 2 incidents in Iowa because we have an older population. So with that said, there are some things that we know are potentially modifiable. Like, again, we do a Cancer in Iowa report every year. And last year, for example, we focused on alcohol use. Alcohol is one of the potential pieces of the puzzle, one of the potential pieces of the pie. And it's one of the modifiable risk factors where Iowa stands out. The other reason we wanted to focus on it is because only 40% of Iowans, not Iowans, 40% of Americans know that alcohol is a risk factor for cancer. And for example, about 22% of Iowans report binge drinking in the last 30 days, compared to about 16.5% of Americans. So it's somewhere that we really, for want of a better term, we excel at drinking in Iowa. And that's one of the places where we could potentially reduce our risk. We know that smoking is a huge risk factor for many different types of cancer, not just lung cancer. And about 15% of Iowans smoke, compared to about 13% of folks in the US. One of the things that we can do, and we were just talking before this about your spin class that you are teaching after this podcast. I did my spin class this morning. Physical activity is great for us, and we know that About 26% of Iowans don't get any leisure time physical activity compared to about 24% of Americans. And so physical activity is one of those things, again, that is so very good for us in so many ways, not just in cancer prevention, but it also does have an impact on our cancer prevention. We have a higher prevalence of obesity in Iowa compared to the rest of the US, about 37% compared to about 33% in the rest of the US. And obesity has been linked to 13 different types of cancer. And then one other place where we actually do pretty okay, but we have a lot of room for improvement, is in our HPV vaccination. About 57% of Iowans are up to date, eligible Iowans are up to date on the HPV vaccination compared to about 59% of eligible Americans. And the reason that that is important is that the HPV stands for human papillomavirus, and HPV is a virus that has been causally linked to many different types of cancer, particularly cervical cancer, but also cancer, anal cancer, penile cancer, oropharyngeal cancer. And these actually we're seeing are on the rise in Iowa. And so it's really important that folks who are eligible for the HPV vaccination consider getting that vaccination, because it really is a cancer prevention vaccine.
Yes. You know, and one that you mentioned was the oral pharynx cancer, and I use that term because it's a technical anatomical term. So it's the part of the throat where the tonsils live. So it's the very back of the tongue and the tonsils. And actually, in the United States, there will be more men with HPV oral pharynx cancer than there will be women with cervix cancer. And cervix cancer is probably the most well-known of the HPV, but it's not as prevalent as the oral pharynx cancer in men. And oral pharynx cancer in Iowa is one of those cancers that we have probably a higher incidence of than many other states.
We are, in fact, last I checked, we just had the new data released last week, so this could have been updated, but we were number one last time I checked. So, and
Yes.
our rate was increasing. So this is definitely somewhere where I think we have a lot of potential to protect Iowans.
Yeah, and it's one of those cancers that the treatment has lots of side effects and lingering, lifelong sorts of side effects. So, right now, there's not a recognized screening test for the oral pharynx, whereas for cervix cancer, that is one of the 5 cancers that we do have a screening test for. It's called a pap smear, and you can actually check for HPV and in doing those gynecologic exams. What other highlights from Cancer 2025 would you like to bring to our attention? We are going to open it up because we've got a large studio audience today, and I know there's going to be lots of questions. So, what other highlights before we go to the studio audience for questions?
Absolutely. So I think just the last thing that I'd like to bring attention to in the report is that we do have, I think, some really great information around survivor needs and survivorship journeys and how they differ. You know, survivor needs can be very different depending on whether you were just diagnosed, whether you've been living with cancer for a long time, whether you're a rural resident, whether you're a young person who's been diagnosed with cancer. And I think that those of us who have not been through a diagnosis of cancer, or who have not have a loved one who've really a close loved one who've been through that, don't necessarily have an understanding of what that means to be a cancer survivor. And so I would really encourage folks to go to the report and kind of get an overview of survivor needs and really to understand the unique needs of this population. And I love that we included stories this year, stories of both patients who have been through the process of being a cancer survivor and how they are kind of coping with that diagnosis, as well as the folks like yourself who are really engaging in the research to support folks who have had a diagnosis to have a higher quality of life. So.
Right. Many people who are cured of cancer may have ongoing, lingering physical, psychosocial, emotional, financial, sexual, spiritual, philosophical issues that can affect them for the rest of their life. Before we go to the audience for questions, two particular unique traits of Iowa that I see. Number one, radon, we know causes cancer, and we in Iowa are kind of like on a hotbed of radon, and that is one of the potential reasons that we may have such a high incidence. And then
Thank you for
a
bringing that
lot.
up, because I completely forgot to say that, and that's really important for Iowans. If you can test and mitigate if necessary, that's a really important thing to do.
And the other factor that many of us are wondering about is environment, because when you look at Iowa and its wonderful fertile land, but then you look at it in terms of the number of tons of chemicals that are put on our land per square inch compared to other states, that seems to also be an outlier that could be a potential explanation. How would one conduct a study that would try to tease out the role of radon and or the role of ag chemicals on where we stand in terms of incidence?
Yeah, I will say that we currently have a project where we are sharing data with every county, every one of Iowa's 99 counties, and we're really using that as an opportunity to listen and to learn from the concerns that Iowans have. And I think we hear this concern a lot, specifically around the agricultural environment in Iowa. And I will say, I think this is really an area where we need to know more. There are some things that we know, and I can share those. But this is, I will say, Iowans are right to be concerned. They're right to ask questions. I think that there are a lot of valid questions and concerns that we need to dig into, and we really need to have more information. So at the Iowa Cancer Registry, we provide the data, right? So we work with folks who have the expertise. I can't answer your question, Dick, because I don't know the answer to that question, because to my understanding, it's really, really hard to measure exposures to things like radon and to agricultural chemicals. But we do have experts who are looking into this. We work closely with the Center for Health Effects of Environmental Contaminants and the Environmental Health Sciences Research Center, both at the University of Iowa, and we share our data with them so that they can do the kinds of studies that you're talking about. The other really big resource that we have here in Iowa is called the Agricultural Health Study. This was a study in Iowa and North Carolina of pesticide applicators. And I can't remember how many they recruited, but it's in the tens of thousands. There were many folks that they recruited, and they really wanted to understand both exposure to certain chemicals and cancer incidence among pesticide applicators and farmers and their spouses. And they had some really interesting findings. There were some, in general, farmers and pesticide applicators have a lower risk of cancer than the general population, but there are some cancers for which they have higher risk. Some blood cancers, for example. And I will just say, again, I'm not an expert in this area, but if you're interested in this topic, at the Iowa Cancer Summit last fall, and you can see all the recordings on YouTube, Laura Bean Freeman from the National Cancer Institute, who actually is the principal investigator of the Agricultural Health Study, did a fabulous talk on the Agricultural Health Study. So I highly recommend, I would just internet search Iowa Cancer Consortium Summit, Laura Bean Freeman, and I'm sure that you can find that, because I think she did a really wonderful job of summarizing what the data are and what cancers we might need to be concerned about in terms of agricultural health risk, and what ones we maybe don't need to be as concerned about, and where we need to learn more.
Okay. We're going to open up for questions.
We've got a question from Kevin, who's watching on Facebook. Kevin asks, do you know of any cancer research programs in Iowa that have been paused because of the uncertainty of continued federal funding?
That is a really good question. Thank you for that question. I think one of the things that I think it was Kevin, you really put your finger on the pulse when you said uncertainty. There's a lot of uncertainty. I do know that some programs that have lost funding or been stopped, including some of my own work. But I think one of the other big things that's really disrupting the work that we're doing right now is the uncertainty. There are several programs which we have funding for in the state that I'm involved with, and the staff who run those programs have received a reduction in force notice. They're federally funded programs, so there's nobody to administer the grants. There are some. I was just at the conference last week and hearing a lot about different grants that have been terminated. And I think the thing that we have to think about with this is that I think we have a lot of folks in Iowa who are really committed to understanding why we have the second highest rates of cancer. And unfortunately, I shouldn't say unfortunately, it is going to take a lot of long-term investment from all of us to really turn this ship around and to really understand and address the issue of cancer in Iowa. And this is where the unfortunately comes in, is I think that the funding cuts and the uncertainty around the funding cuts are definitely not helping us really get to where we need to be to understand the burden of cancer. And for example, we have heard that there may be a funding cut coming to the Iowa Cancer Registry and all of the registries nationwide. And that could have severe impacts on our ability to tell you which cancers we have in Iowa. So again, I can't tell you anything for certain because I think there is a lot of uncertainty. But I think this is an opportunity for us to work together to talk to our legislators if this is something that's important to you, and really press to them the importance of continuing to fund the work that we're all doing to address the burden of cancer in Iowa and to improve the health of Iowans.
Great. Thanks. We have other questions?
Okay. Thank you so much for your time. I really appreciate it. This has been just enlightening. I am a recent cancer survivor and particularly interested in the environmental risk factors for cancer. So thank you for touching on that. In addition to that agricultural study, which you mentioned, which I can't wait to go home and I'm going to look up that presentation. Is there any current research happening or future research planned specific to Iowa's public water supply?
Yeah,
and nitrates in water, just the toxins in water.
Yeah, so the Center for Health Effects of Environmental Contaminants or Contamination, I can never remember, CHEEC, is the abbreviation at the University of Iowa, is very interested in this topic. So they have a couple of experts there who are really digging into nitrates and trying to understand. We are sharing our data with them to see if we can better understand this relationship between nitrates and cancer risk. Again, it's hard to do. The measurements are not easy, and it's one of the things that we have a problem with these kinds of studies, that it's very hard to link exposure in an individual to cancer in an individual. We're often looking at exposure in an area and trying to link it with cancer in an individual, and that gets very complicated, but we are doing the best we can to answer these questions and to look into that. So I would suggest if you're interested, I think they have a pretty good website, this CHEEC at the University of Iowa, CHEEC. And the other thing I wanted to add actually also is that the Environmental Health Sciences Research Center, we've been collaborating with them, and they just put out a couple of really good fact sheets on different environmental exposures that can tell you about the environmental exposure and the diseases, the chronic diseases that they may be linked to. So check those out if you're interested in learning more.
Well, you talked about the difficulty, and I think back the association between the act of cigarette smoking and lung cancer. I mean, a fairly one-on-one sort of association, and it took a few decades. And now we're talking about probably thousands of different chemicals. I mean, we're talking not only ag chemicals, but PFASs and plastics and food dye and all of the different chemicals that modern life have thrown at us. So thousands of chemicals and probably dozens of cancers. And the idea of trying to find this smoking gun or this cause and effect association, it's no wonder that there's difficulty in coming up with the firm, irrefutable data on cause and effect.
I really appreciate you saying that, Dick, because it's really complicated, and I don't do that work, so I'm not the best person to really dig in and tell you how and why it's complicated. But my training is all in nutrition, and nutrition is complicated enough. Like the science is ever evolving, and it's really hard to tell. Even when we have a good idea of what somebody eats, it's very hard to make that link. Like you said, smoking and lung cancer is what we like to think of as probably the most direct link that we will probably ever get in the history of the field of epidemiology, or at least chronic disease epidemiology. And that took a long time to prove. And so I think you're right. I think that it's complicated, it's difficult, and we're really trying to do the best we can. We really do want to improve. We're here to help improve the lives of Iowans and reduce the burden of cancer in Iowa. And I appreciate that we're all going to have to work together to answer these complicated questions.
Okay. Other questions? George.
Mary's watching on YouTube tonight. She says every pig confinement operation emits 200 pounds of pig manure particulate each day. Can this be a big part of lung cancer in Iowa? In other words, the things we're looking here that are not the same with Iowa and other states. We have thousands of pig confinement operations in Iowa, as does North Carolina. 24,600,000 pigs in Iowa as of December 2024.
That is a lot of pigs. That's probably a lot of pigs per Iowan. I'm trying to do the math in my head.
It is. And just to amplify that, I was at a conference on hog confinement, and when the amount of manure that a hog makes per day is a lot more than a human does. So when you take the number of hogs and the amount of manure, it would be equivalent to Iowa having like a 20 million population. The amount of manure that is generated by all of the confinement, the animal confinement operations. So yes, how would one go about trying to determine whether the amount of manure from animal confinement operations is contributing to the increased risk of cancer?
That's a really good question, and to answer the original question, I don't think we know that. I think that's one of the things we could look into when we are trying to understand the link between environment and cancer in Iowa. To answer I feel like I'm in a PhD comprehensive exam, and you're asking me to design a study on the fly. But I think it would be it could be really complicated, right? Because you have to really carefully measure that exposure, and it's not just the amount of manure that is produced, it's the amount of manure and the amount of particulates that a person is exposed to. And that can be really difficult to measure. So again, I think it's going to take a lot of us with a lot of different sets of expertise to really work together and answer these kinds of questions.
Okay. Other questions? Yes.
I have great acceptance of your data and the studies and those that are around the country that have been done that maybe won't continue. I don't know. But I think intellectually you're there, and then there's this emotional tie-in about how afraid you are. And there's not anyone, there's just so much cancer in Iowa right now. I think people are kind of just don't want to talk about it, and you don't want to know how far do I have to go to a hospital to get treatment, and what does it mean? So with the intellectual and the emotional charge thing, the resistance that is there, I think political will or resistance to going forward with research and giving people answers that maybe change how they eat or how they farm or what water they drink. I just think it's perplexing. And I think we have to deal with the mindset as we look at this data and how you teach us to learn, accepting what you give us as the data.
I really appreciate that comment, and I thank you for sharing that. And this is why I think at the beginning I shared that I like to think of our data as a collection of stories, because that's what it is. It's a collection of stories. It's a collection of stories about people's cancer journeys. And I think sometimes scientists can forget that. We see these numbers, these maps that we make, and we forget that each one of the numbers that we have in our map is a person. It's and Mary Charlton, our PI, has a quote: statistics are data with the tears wiped away. I think is the quote. Because I think sometimes we forget about that emotional component, and I think you're right. It is going to take a lot of us working together to turn this ship around, and I think it's really important that we educate the folks who have that political will to make sure that we're investing in this for the long haul. I was really pleased. I think many of us were really pleased to see that Governor Reynolds is putting some money in the budget towards understanding why Iowa has high risk of cancer, and I just would say, I think this is going to be required for a long time. I was just talking to Kelly Siddick last week, who's the executive director of the Iowa Cancer Consortium, and she puts this really nicely. She says, this is a large, complicated problem that was many years, if not decades, in the making, and it's going to be a large, complicated problem to solve, and it's going to take us years, if not decades, to understand it and to turn it around. And so it's exciting to see that the Governor Reynolds is interested in investing in the research, and I think that investment needs to continue because, like you say, it's affecting Iowans. Cancer is affecting Iowans. We all know somebody who has been diagnosed with a case of cancer, and I think that that's it's so complicated. It's going to take all of us working together to address the issue. And I really thank you for your comment, because I think sometimes we forget about that emotional piece.
Yes.
Ms. Nash, thank you for your presentation. It's been very enlightening. I don't know, but my understanding from the definition of an epidemiologist that Dr. Deming asked you about at the outset was part of it is causation.
Mm-hmm. Yep.
And, we have a history in our country that for years and years and years, the tobacco industry covered up the evidence that, eventually came out by the Surgeon General and other great researchers like yourself and Dr. Deming that produced what we now think of as, where were they all these years? Mm-hmm. So, on the causation part of your work, when, if ever, does an epidemiologist feel that, well, I can now conclude to, pardon the expression, a reasonable degree of certainty that there is, in fact, a causal relationship between X and my diagnosis of cancer? Sorry for the long question.
No, and I'm chuckling because I feel like we joke about this is an epidemiologist joke, that our favorite phrase is, it depends. We don't like to say that X causes Y, because there's always something else that could be playing in. There's always a complicated web of factors, right? So I'm laughing more at us as epidemiologists and our inability to say exactly what you're asking us to say, which I think is what we need. And I think again, I think I've heard you mention this. I've heard Dave Swartney mention this at Cheek, but I think at some point we have to say we don't necessarily know all of the causes, but at what point do we have enough information to move forward? And I think that we have to make sure that we're supporting the research so that we can get to that point. And I will share an opinion that is my own opinion and not the opinion of my employers. But I think, to me, this is why government-funded research is so important, because if we privatize research, then I'm not sure that we can ever really get unbiased research. And I think that's, to me, why it's so devastating to see attack on governmental research spending, because it's that governmental research spending that allows us to, for example, do the research that the tobacco companies didn't want us to do. And I really agree with you. And I think at some point we just have to make that statement that we may not think we know it all, but at what point do we know enough?
Mhm. When is there a preponderance of data
Absolutely.
that we, and so if we look back at when did that happen with tobacco, when did that happen with alcohol, when did that happen with HPV, what was the preponderance? And now we think back and it seems like, oh, we've always known that those have caused, like obesity causing cancer. When did we feel that there was a preponderance of evidence that we just now stated as a fact, and we don't um, make it a relative statement based on the current data today suggests? We just say, yeah, obesity causes cancer.
Well, I would say that as any good scientist should, we never take anything as fact, because we always have to be able
Yes.
to revisit our assumptions and say, you know what, we thought that this was a fact, but turns out it's not. And we
Yes.
have to revisit what we think we know.
The
But
smartest scientists in one era all were convinced that the world was flat, and they were smart, but they were wrong.
Exactly. So I think that this is one of the things I love about science as a scientist, is that we're constantly questioning ourselves and trying to learn more. But again, to the last question's point, we get to a point where we have to say that based on the evidence that we know now, this is how we have to move forward at this time.
Mm-hmm. Yep. I think we have time for one more question. Don't be shy. Okay, I get the last question.
All right.
So, Sarah, what are you most excited about in terms of the future of science and maybe the future of epidemiology as it relates to cancer?
That is a really good question that I don't think anybody asks us enough, Dick. So thank you. That's a really good note to end on. And I will just share something that I am really excited about right now in Iowa that I've mentioned briefly. And because we've been talking about cancer in Iowa. And so I think one of the things that I'm excited about in terms of cancer in Iowa is that so we are doing this project right now with the Iowa Cancer Registry, the Iowa Rural Health Association, the Iowa Cancer Consortium, and the Holden Comprehensive Cancer Center, that is going out to each of Iowa's 99 counties and sharing and listening and learning. And that gives me a lot of hope. It gives me a lot of hope because people are interested, people are coming to the presentations, people have great questions, they have great concerns. And I think I've said probably ad nauseum in this podcast that it's going to take all of us to turn this ship around. And that project has really made me see, and I love community engagement anyway, it's baked into the research that I do, but I feel like it's really hit home through that project that we have a lot of folks in Iowa who have a lot of strengths, and working together, I really do believe that we can turn the ship around.
Great. Thank you. Our guest this evening has been Dr. Sarah Nash, the Director of Research at the Iowa Cancer Registry. Thank you, Sarah.
Thank you for having me.
And if anyone watching this knows someone that would benefit by watching this program, it will be available to all of you on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.